In the spring of 1986, a radiation therapy machine in Tyler, Texas, delivered a dose of radiation to a cancer patient that was somewhere between 400 and several thousand times the prescribed amount. The machine was called the Therac 25. It had been cleared for clinical use, trained staff were operating it, and everything about the setup looked correct. The treatment began, and then it didn't. The investigation, and it took multiple accidents before investigators understood what they were looking at, found a software race condition. Two processes in the control system could interfere with each other if an operator entered commands within a very specific timing window. When that happened, the machine fired its high-energy electron beam directly without the scanning magnet that would have spread it safely across the treatment field, while displaying a relatively minor error code on the screen. That race condition had been in the code for some time before anyone was hurt. Devices were deployed at multiple facilities. Staff were operating them, and nothing happened because the race condition alone, as a technical fact about the software, wasn't enough to cause harm. It needed something else. It needed a very specific person behaving in a very specific way at the wrong moment. What it needed was an experienced operator, specifically someone who had worked with the Therac 25 long enough that clearing error messages had become muscle memory, a sequence they could execute in seconds without thinking. That speed put them inside the timing window where the race condition fired. The very thing that made them competent at their job was the thing that activated the hazard. And the reason this took so long to trace is that the incidents looked different in the clinical record. Different facilities, different doses, different clinical presentations. Nobody connected the pattern until investigators went back and mapped the full sequence across multiple cases, examining operator behavior, machine state, timing, and outcome together. The chain only became visible when someone documented it explicitly. That mapping across cases is what revealed the systemic cause. Without the chain, each accident looks like a random event. With it, the cause is obvious. A hazard, a sequence of events, a hazardous situation, and then the harm. That chain, those four concepts, is the foundation of ISO 14971, Clause 3. And it's the vocabulary that separates a risk file that holds up in an audit from one that doesn't. Not because the words are magic, because the concepts force you to document the path, and the path is where the risk actually lives. Most engineers who've been through occupational health and safety training learned a model with two terms: hazard, anything that can cause harm; risk, the combination of how likely that harm is and how serious it would be. Two steps, P times S. And for general workplace safety, slip and fall risks, chemical exposure limits, equipment guarding, that model works. It's been refined over decades of practice, and it's adequate for what it's designed to do. Medical devices have a problem with that model, though. When your device can deliver the wrong drug concentration or generate an electrical fault current or fail during a sterile procedure, the two-step model doesn't give you enough resolution to document what you actually know about the risk. You know more than hazard exists, therefore P times S. You know how the hazard becomes a harm. You have a path, and the two-step model has no place to put the path. I'm Dave Saunders, 30 plus years in medical devices and regulatory affairs, development, submissions, post-market, and plenty of time in audit rooms watching risk files get evaluated. The specific gap we're talking about today between how general safety vocabulary works and what ISO 14971 actually requires is a real gap that shows up in real risk files, and it's one that's correctable once you see it clearly. ISO 14971 adds a third term between hazard and harm, hazardous situation. And the question worth spending time on, the one this module is going to answer in detail, is what is a hazardous situation doing that the two-step model can't? Why does the standard need it? The answer explains the entire architecture of the risk analysis section of your risk file. In this module, we're covering all 31 defined terms in ISO 14971 Clause 3, every one of them. But we're going to spend the most time on the 8 or 9 that drive everything downstream, the chain, the probability structure, the process vocabulary. And we're grounding every definition in WearPump so you leave with a concrete worked example, not just terminology. Clause 3 of ISO 14971 is the Terms and Definitions clause. 31 terms, each with a definition precise enough that the rest of the standard can use it unambiguously. Some of these terms are intuitive and a sentence is enough. Others are structural. They define the vocabulary the entire risk management framework is built on, and you need to understand them at the level where you can apply them, not just recognize them when you see them. The 31 terms organize naturally into clusters: the chain, hazard, hazardous situation, harm, risk, probability, severity. The process, risk management, risk analysis, risk estimation, risk evaluation, risk control. The context, intended use, reasonably foreseeable misuse, use error, life cycle, accompanying documentation. And then terms like safety, state-of-the-art, benefit, and objective evidence that underpin the framework across multiple clauses and modules. We're going to cover all 31. For the process and context terms, a precise definition and a clear example is usually sufficient. For the chain, hazard through risk, we're going deep because those terms are the architecture your risk analysis is built on. Misunderstand them and your p-values are measuring the wrong thing. Understand them and the whole risk file structure becomes logical rather than procedural. And at the end of this module, WearPump will have its first 4 entries in the risk analysis section of the risk management file. 4 hazards, each mapped through a documented sequence of events and a specific hazardous situation to a characterized harm. That's the first structural work in the risk file. The entries that modules 5 through 9 will build from into a complete risk assessment. Term 1, hazard. ISO 14971 Clause 3.4, a potential source of harm. 5 words. And the precision of those 5 words is part of the point. Potential is doing the real work there. A hazard hasn't caused harm yet. It's a property of the device or of the energy, material, or process associated with it that has the capacity to cause harm under the right circumstances. The high-pressure spring in a drug delivery mechanism is a hazard. The electrical current flowing through a circuit board is a hazard. The sharp edge of a scalpel is a hazard. Concentrated drug in a cartridge is a hazard. None of these have hurt anyone yet. They're potential sources of harm that could, under the right circumstances, become actual harm. The circumstances are the next term, hazardous situation, but we're not there yet. The hazard is where you start. This framing, hazard as a property of the device rather than a description of what happens, matters for how you write your risk file. When you document hazard, high pressure reservoir, you're making a claim about the device's physical state. You're not yet making a claim about who might be hurt, in what circumstances, or how likely it is. Those come later in the analytics. The hazard column is where you inventory the potential energy in the device. ISO 14971 and its supporting guidance document ISO 24971 give us hazard categories as a starting checklist. Energy hazards: electrical, thermal, mechanical, acoustic, ionizing, and non-ionizing radiation. Biological: contamination, infection, toxicity. Chemical: drug concentration, material biocompatibility, outgassing, and use-related hazards, use hazards, software defaults, labeling deficiencies. The categories aren't a closed taxonomy. They're a systematic prompt to make sure you haven't overlooked an entire class of hazard. One thing that catches people, hazardous situations can arise even when the device is functioning exactly as designed. The standard requires you to analyze both normal conditions and fault conditions. A sharp cannula during normal intended use is a hazard under normal conditions. A software race condition under a specific input combination is a hazard under fault conditions. Both belong in your hazard identification. Limiting your analysis to what if something breaks leaves out a whole class of normal use risk. For WearPump, 4 fundamental hazards. First, the pressurized insulin reservoir, up to 3 milliliters of insulin stored under tension in the delivery mechanism. That's stored mechanical energy. If the reservoir releases in the wrong place or at the wrong rate, the energy becomes a source of harm. This is a normal condition hazard. The pressure is there intentionally as part of how the pump works. Second, concentrated insulin, the pharmacological properties of the drug in the cartridge. Insulin is a potent pharmaceutical, and the delivery system's job is to get precise quantities into the patient's bloodstream at precise times. That precision is also a source of risk. Errors in dose quantity, dose rate, or timing have direct and sometimes rapid physiological consequences. The drug that makes the device effective is also, at the wrong concentration or rate, a hazard. Third, electrical energy from battery, motor, and Bluetooth subsystems. Anywhere electrical energy flows through a system, and WearPump has several electrical subsystems, there's the potential for it to reach places it's not designed to go. Fault conditions in the circuit can create unexpected paths to the patient's tissue. Normal operation of the Bluetooth radio creates electromagnetic emissions that, in certain environments, could affect other devices. And fourth, the skin adhesive and infusion interface. WearPump adheres to the patient's body for up to 72 hours and introduces a subcutaneous cannula. The sustained contact creates biological and mechanical hazards at the skin device boundary, adhesive chemistry, physical pressure, microtrauma from the cannula, and the introduction of a portal through the skin's natural barrier. 4 hazards, not 4 risks, not 4 harms, 4 potential sources of harm that we now need to trace through the chain. Term 2, hazardous situation, clause 3.5, a circumstance in which people, property, or the environment is exposed to one or more hazards. The word doing the most work in that definition is circumstance, not hazard, not harm, a specific set of conditions involving a specific hazard and a specific person or thing being exposed to it. The circumstance is what connects the hazard to the possibility of harm. A hazard is a property of the device. A hazardous situation is what happens when a person or property or the environment comes into contact with that hazard through a specific sequence of events. The sequence of events is the path from hazard to exposure. The hazardous situation is the destination. The moment when the potential for harm becomes an actual possibility rather than a theoretical one, this is where the analysis stops being abstract and starts being about real people in real conditions. For connected devices like WearPump, it's worth pausing on software and cybersecurity as hazard sources. A software fault, an unhandled exception, an overflow condition, an incorrect calculation is a hazard, but a cybersecurity vulnerability is also a hazard. An attacker who exploits a Bluetooth vulnerability doesn't become the hazard. The vulnerability itself is the potential source of harm. The hazardous situation is the exploitation of that vulnerability in a clinical context. ISO 24971 addresses this explicitly. And this is the structural answer to the question we opened with. probability doesn't attach cleanly to a hazard. A pressurized reservoir is either under tension or it isn't. The hazard exists or it doesn't. But probability attaches to a sequence of events, to the specific chain of circumstances that brings the hazard and a person together in a way that could cause harm. The hazardous situation is where that chain ends, and that is where your p-value belongs. Go back to the Therac 25. The race condition is the hazard, but the hazardous situation isn't. Race condition exists in the code. The hazardous situation is this specific set of circumstances. Experienced operator clears the malfunction message during the timing window. Machine fires the high energy beam without the scanning magnet. Patient is in the treatment position and receiving the beam. That is the circumstance of exposure. That is the probability you care about, not whether the code has a flaw, but whether that specific sequence of events occurs during a treatment session. A single hazard can lead to multiple hazardous situations through different sequences of events. The pressurized reservoir in WearPump doesn't have one path to exposure. It has several, and each path deserves its own entry in your risk analysis because each will have a different probability of occurring, a different population of patients and caregivers involved, and a different severity profile for the harm that could result. One hazard, multiple hazardous situations, multiple risk entries. Hazardous situation A for the pressurized reservoir hazard, an occlusion develops in the infusion tubing, kinked catheter, tissue reaction, clotting. The pump motor continues attempting delivery. Pressure builds in the closed system. The fitting at the cannula junction fails under the accumulated load, releasing a bolus of insulin into the subcutaneous tissue before the system detects the fault and alarms. Specific path, specific exposure, specific population. Any patient wearing the device. Hazardous situation B for the same hazard. Patient drops the pump from height. The fall dislodges the cartridge from the drive mechanism. Sudden decompression releases insulin through the cannula before the patient can remove the infusion set. Completely different sequence of events. Same underlying hazard, pressurized reservoir. But different path, different probability estimate, different population at risk, potentially different harm profile. Both go in the risk analysis. Collapsing them to a single entry loses information. The sequence of events column in a hazard traceability matrix isn't optional or decorative. It's the documentation that makes your probability estimate traceable. When an auditor asks you how you arrived at your p-value, the sequence of events is the answer, the causal path you evaluated. If the path isn't documented, the p-value is an assertion rather than an estimate, and assertions don't satisfy Clause 5.4. Term 3, harm. Clause 3.3, injury or damage to the health of people or damage to property or the environment. 3 things worth noting. First, it's not limited to physical injury. The standard explicitly includes psychological harm. A false positive result from a diagnostic device that causes a patient lasting anxiety is a harm in ISO 14971 terms. Second, the 2019 revision made damage to property and the environment explicit, not implied. Third thing to notice, harm includes harm to people, plural, and not limited to the primary patient. Caregivers, family members, clinicians, bystanders. A WearPump malfunction that creates a spill of insulin in a clinical setting could affect a healthcare worker who contacts the spill or inhales aerosolized drug. A fault that causes a fire hazard affects whomever is in the room. Your harm analysis needs to consider the full range of people who might be exposed through each hazardous situation. Severity, Clause 3.27, is a measure of the possible consequences of a hazard, and severity is not binary. For WearPump, an unintended insulin delivery ranges from mild, where the patient notices a glucose drop, eats something, and recovers without clinical intervention, all the way to severe hypoglycemia, leading to unconsciousness, seizure, and potentially a fatal outcome. That full range can come from the same hazardous situation at different times of day, exercise states, or meal timing. When you're documenting harm, you document the full severity range, not just the worst case and not just the typical case. Different sequences of events from the same hazard can reach different points on the severity spectrum, and the severity you document needs to connect to the specific hazardous situation. It's the consequence of that exposure under that set of circumstances in that patient population. Severity divorced from the hazardous situation is just a guess. There's a time dimension to harm that affects your probability estimates. Some harms are immediate. The patient knows within seconds that something is wrong and can take action. Others are delayed. An infection from a compromised cannula site might not become apparent for 24 to 48 hours. The latency affects whether the patient or a caregiver can intervene before the harm becomes serious, which in turn affects P2, the probability that the hazardous situation leads to clinically significant harm. The chain, hazard, a potential source of harm, a property of the device. Sequence of events, the path from hazard to exposure. Hazardous situation, the circumstance of exposure. Harm, the consequence at some level of severity. 4 concepts, 4 columns in your risk analysis table. 1 continuous narrative that says, here is what the device carries, here is how that thing reaches a person, here is the moment when harm becomes possible, and here is what happens. This isn't just a teaching framework, it's what Clause 5.4 of the standard requires. Clause 5.4 says you must identify the sequence of events that could result in a hazardous situation, not identify hazards and estimate risk, not list the things that could go wrong. Identify the sequences of events. The chain is the clause's requirement expressed as a data model, and your risk analysis is the populated instance of that model. When an auditor goes to your risk analysis, they're running structural checks. Does every hazardous situation trace back to a named hazard? Does every harm trace back to a named hazardous situation? Is the sequence of events written out, not implied, not summarized, written out specifically enough that someone else could evaluate the probability estimate? If any of those answers is no, there's a finding. These aren't judgment calls, they're structural checks against the clause requirements. In Module 5, we'll run a systematic hazard identification exercise using 2 complementary analysis techniques, FMEA, which traces forward from failure modes to hazardous situations, and fault tree analysis, which traces backward from harms to find the combinations of events that could cause them. You need to understand the chain structure now so you can use those tools effectively then. The techniques are disciplined ways to populate the chain, not substitutes for understanding it. Those 2 tools work in different directions through the chain, which is why they complement each other. FMEA starts with your device's potential failure modes and traces forward. What could fail, and where does that failure propagate towards a hazardous situation? It's effective at identifying single-point failures. Fault tree analysis starts with an undesired harm and traces backwards, using logical and/or gates to find the combinations of events that could produce it. Together, they cover the chain from both ends, forward from the device failures, backward from patient harms. The chain is the vocabulary. The harder question, the one that determines whether the numbers in your risk file are defensible, is understanding exactly where the probability lives inside that chain. P times S is the formula, but the P has a structure that's more specific than it looks, and most early risk files miss it. Risk. Clause 3.18, the combination of the probability of occurrence of harm and the severity of that harm, P times S. And the operative word in the probability side is harm, not hazard, not hazardous situation. The probability of occurrence of harm, the thing at the end of the chain. If your p-value is actually measuring something else, the risk estimate is off. Severity is the more traceable half of the formula. You're categorizing the magnitude of harm using a defined severity scale, what the standard calls the consequence. We'll build WearPump's severity taxonomy in Module 3 when we write the risk management plan: minor, serious, critical, catastrophic, and fatal, or whatever 5-category taxonomy your plan establishes with specific definitions and defensible rationale for each tier. Probability is more subtle. The question isn't just what is the probability? The question is probability of what? And if you answer probability that this failure mode occurs or probability that this component fails, you've attached your P to the wrong place in the chain. The standard says probability of occurrence of harm, which means the probability of the entire chain running to completion, not just the probability that the hazard exists or is activated. For WearPump's reservoir hazard, the wrong P is probability that an occlusion occurs. The right P is probability that an occlusion occurs and pressure builds to failure and the drug bolus is delivered and the patient experiences clinically significant hypoglycemia. That's the probability of harm. It's a compound probability across the full sequence. An occlusion is relatively common. An occlusion that leads to all of those sequent steps is much less common. The distinction matters enormously for your risk estimate. One useful way to think about the probability structure, it has 2 components. P1 is the probability that the hazardous situation occurs, that the specific sequence of events that creates exposure actually happens. P2 is the probability that once the hazardous situation exists, harm results. The P you assign to a risk file entry is the combined product of both. Missing P1, which is common, means your P is only measuring the danger of the exposure, not the likelihood of getting into the exposure in the first place. For Therac 25, P1 would be the probability that an experienced operator is at the console and types through the setup sequence quickly enough to fall within the race condition timing window on a given treatment. Small. Only the fastest and most experienced operators could do this. P2, given that situation, is the probability that the machine fires the unscattered beam and delivers a harmful dose. Those 2 components together define the risk. Each one alone tells you almost nothing. When an auditor looks at your P column and asks, how did you arrive at this number? What they're evaluating is whether you've thought through the actual path. A p-value that's traceable to a documented sequence of events, supported by failure rate data, human factors study, clinical data on comparable devices, or engineering judgment with explicit rationale, is defensible. A p-value that arrived intuitively and isn't connected to the sequence is not. A rationale is part of the risk file. ISO 24971, the technical report that supports the standards application, has an annex specifically on probability estimation. It lists the categories of evidence you can draw on: published failure rate data for comparable component technologies, field data from similar devices in the post-market literature, human factors validation results from usability engineering activities, engineering analysis using fault tree or Markov models, and structured expert judgment. For a new device without field history, a combination of component reliability data and human factors test results is typically the starting point. The estimates sharpen as post-market data accumulates. For a new device without field history, your P estimates will be semi-quantitative at best, grounded in comparable device failure data, component reliability specifications, human factors study results from usability testing, and engineering judgment. The standard accepts this. What it requires is that you document your rationale, that the rationale is tied to the specific hazardous situation, and that you update the estimates as real-world data becomes available after market launch. Now for the rest of Clause 3, Safety, Clause 3.26. Freedom from unacceptable risk, not zero risk, not the absence of hazards. Freedom from unacceptable risk, where acceptable is defined in your risk management plan, and the threshold is grounded in your risk acceptability criteria and the state of the art for your device category. This definition has different weight now that you have the chain. You cannot remove the hazard from WearPump. Insulin concentration is intrinsic to what the device does. Safety doesn't mean we eliminated the hazard. It means we've ensured that the risks arising from that hazard through their documented hazardous situations and their documented paths to harm fall within our risk acceptability criteria. The chain is what you're managing. The hazard is given, and the work is the analysis and control of what flows from it. Risk Management, Clause 3.24, the systematic application of management policies, procedures, and practices to the tasks of analyzing, evaluating, controlling, and monitoring risk. 4 tasks: analysis, evaluation, control, monitoring. They're sequential. Each one consumes the output of the previous. We're in analysis right now. Evaluation is Module 7, where we'll compare WearPump's estimated risks to the acceptability criteria. Control is Modules 8 and 9. Monitoring is Module 12. Risk analysis and risk assessment are terms people use interchangeably in practice, but in ISO 14971, they have precise meanings. Risk analysis, Clause 3.19, is the systematic use of available information to identify hazards and estimate risk. Risk assessment, Clause 3.20, is the umbrella term covering both risk analysis and risk evaluation. Analysis produces the estimates. Evaluation produces the verdicts. Assessment means you've done both. Getting these confused in your documentation creates audit findings. Risk estimation, Clause 3.22, the process used to assign values to the probability of occurrence of harm and the severity of that harm. That's what we'll do in Module 6 for WearPump. Populate the P and S columns for every hazardous situation we've identified. Risk evaluation, Clause 3.23, comparing those values to your risk acceptability criteria to determine whether each risk is acceptable in the ALARP zone or unacceptable and requiring control. Risk control, Clause 3.21, the process in which decisions are made and measures implemented by which risks are reduced to or maintained within specified levels. Modules 8 and 9. And residual risk, Clause 3.17, the risk remaining after risk control measures have been implemented. There is always a residual risk in a medical device. A scalpel that cuts tissue has residual risk. A drug delivery device that delivers a drug has residual risk. The question is whether it's acceptable and whether it's outweighed by clinical benefit. The risk acceptability criteria you define in the risk management plan, covered in Module 3, have to be specific enough to make a binary decision from a P and S estimate. A criterion that says as low as reasonably practical is a principle, not a threshold. A working criterion specifies at this P and this S, a risk is acceptable without further control. At these values, it's in the ALARP zone requiring documented justification, and at these values, it's unacceptable and must be reduced. The rationale connecting those thresholds to clinical evidence and state-of-the-art comparisons goes in the plan alongside the criteria. 2 terms worth more than a sentence each: reasonably foreseeable misuse, Clause 3.15. Use of a product or system in a way not intended by the manufacturer, but which can result from readily predictable human behavior. The word reasonably is doing scope-limiting work. You're not required to anticipate every conceivable misuse. You're required to anticipate the ones that predictable humans, under real-world conditions, will actually do. Convenience, distraction, time pressure, and optimism bias are all real. For WearPump, a patient extending wear time beyond 72 hours because they're traveling and don't want to change the device is reasonably foreseeable misuse. A caregiver administering a correct bolus without checking the patient's current glucose levels first is reasonably foreseeable misuse. A parent who who submerges the device longer than the IPX4 rating allows because they want the child to swim normally is reasonably foreseeable misuse. These aren't device failures, they're human behaviors that create hazardous situations your risk analysis must document. Use error is a different concept. Clause 3.30, a user action or lack of action that leads to a different result than intended by the manufacturer or expected by the user. Use error doesn't require intent to deviate. A clinician who programs the dose rate 1 decimal place too high isn't misusing the device. They're making a mistake. The distinction matters because misuse and use error are analyzed differently, require different controls, and point to different sections of the instructions for use. Use errors are also analyzed in parallel under IEC 62366, the Usability Engineering Standard. Benefit, Clause 3.2, a positive impact or desirable outcome of the use of a medical device on the health of an individual or a positive impact on patient management or public health. This becomes essential in Module 9 when we do the benefit-risk analysis for WearPump's residual risks, the ones that remain after we've applied all feasible controls. The question becomes, does the clinical benefit of continuous subcutaneous insulin delivery with all it offers a type 1 diabetic patient outweigh the residual risk profile we've documented? State of the art, Clause 3.28. The developed stage of technical capability at a given time based on relevant consolidated findings of science, technology, and experience. Notice, not the most technologically advanced solution possible, the generally accepted practice in the field. When regulators and notified bodies evaluate whether your risk controls are sufficient, they use state-of-the-art as the floor, not the ceiling. A control that was adequate 10 years ago may not be adequate now if the field has moved. Life cycle. Clause 3.8 covers all phases from initial concept through decommissioning and disposal. Risk management covers the whole life cycle, not just development and clinical use. Transport, installation, maintenance, repair, and end of life all create hazardous situations that belong in the analysis. Objective evidence. Clause 3.11 is the standard's way of requiring that your conclusions rest on data, observations, and measurements rather than assertions. Those two terms together set the scope and the evidentiary standard for the entire risk file. Two more. Verification, Clause 3.31, confirmation through objective evidence that specified requirements have been fulfilled. This shows up in risk control. You don't just implement a control, you verify it's effective. And accompanying documentation, Clause 3.1, covers the instructions for use, technical description, and other materials that come with the device. Labeling and IFU are part of the risk management system. Information for safety is one of the 3 tiers of risk control under Clause 7. Intended use deserves its own moment. Clause 3.11, the objective intent of the manufacturer regarding the use of a product, process, or service as reflected in the specifications, instructions, advertising, and sales promotion material. It's one of the most contested terms in submissions and audits because it defines the outer boundary of your hazard analysis. Everything outside intended use is either reasonably foreseeable misuse, which you must analyze, or unforeseeable misuse, which you document as beyond scope. If the intended use statement is vague, the boundary is vague, and your hazard identification has no principled place to stop. The remaining terms, manufacturer, IVD medical device, post-production, procedure, process, record, severity, and top management, we've either defined them in context or they're clear enough from the standard's plain language. Every one of them appears somewhere in the risk management process. You don't need to memorize Clause 3, you need to know where to look and what the definitions require when you're building an actual risk file. These 31 terms aren't independent definitions. They form an architecture. The chain of terms define what you're analyzing: hazard, sequence of events, hazardous situation, harm. The process terms define how the analysis is structured: risk management, analysis, estimation, evaluation, control, monitoring. The context terms define the boundaries: intended use, misuse, life cycle, and the evidentiary terms: objective evidence, verification, accompanying documentation. They all define what counts as proof. The vocabulary is the framework. Risk management without it is opinion. With it, you have a defensible, auditable record. Now the deliverables. WearPump's first 4 risk analysis entries. 4 hazards mapped through the full chain: hazard, sequence of events, hazardous situation, harm. This is the format your risk analysis table will follow for every entry. And every entry will have a row in the hazard traceability matrix that becomes the working document for the rest of the risk management process. Entry 1, hazard, pressurized insulin reservoir, mechanical energy stored under tension. Sequence of events, occlusion develops in infusion tubing. Pump motor continues attempting delivery. Pressure builds in the closed system. The cannula junction fitting fails under load. Hazardous situation, patient is exposed to a sudden, unintended insulin bolus delivered subcutaneously. Harm, hypoglycemia. Severity ranging from minor glucose reduction requiring a small carbohydrate intake through modern symptomatic hypoglycemia to severe hypoglycemia with loss of consciousness. Entry 2, hazard, concentrated insulin, pharmacological energy. Sequence of events, air enters the infusion set tubing during a cartridge replacement. User does not fully prime the set before reattaching. Air bubble precedes the next scheduled insulin dose. Hazardous situation, patient receives no insulin or significantly reduced delivery during a period when they believe delivery is proceeding normally. Harm, hyperglycemia or diabetic ketoacidosis developing over 1 to several hours, with delayed recognition of the problem increasing severity. Entry 3, hazard, electrical energy in battery and motor drive circuit. Sequence of events, a component fails and creates a fault current path to the device housing. A patient or caregiver contacts the exposed conductive surface while the device is active. Hazardous situation, person receives an unintended electrical shock through contact with a fault current bearing surface. Harm, localized skin burn at the contact site, cardiac arrhythmia in a susceptible patient, or at the extreme, ventricular fibrillation. Entry 4, hazard, adhesive and subcutaneous cannula at the skin interface. Sequence of events, patient wears the device for extended hours in a high moisture environment, exercise, swimming, bathing. Adhesive integrity degrades progressively. Cannula creates sustained mechanical irritation at the infusion site. Hazardous situation, prolonged chemical and mechanical irritation at the skin device boundary. Harm, contact dermatitis, skin breakdown, or cannula site infection developing over 24 to 48 hours of continued wear. 4 entries, 4 hazards, each with a documented sequence of events, a named hazardous situation, and a harm profile with a severity range. This is the beginning of WearPump's risk analysis. In Module 5, we'll run a systematic hazard identification using FMEA and fault tree analysis and expand this to 12 or more hazardous situations. But every entry will follow the same chain because the chain is the structure. Clause 5.4 requires, and getting it right from the start means the rest of the analysis builds on solid ground. One thing I'm genuinely curious about from people working through this material, what's the hazardous situation in your own device that surprised you when you actually wrote out the sequence of events? Because in 30 years of watching risk analysis get built, the hazardous situation you wouldn't have captured if you were just listing hazards, the one that only showed up when you forced yourself to write the path, is often the one with the most significant risk. If you've found one of those, I'd like to hear it. Drop it in the comments. If this module was useful, subscribe, and Module 3 comes your way when it's ready. More on risk management and medical device regulatory practice at baserealitygroup.com. And if you want to go deeper, there's a newsletter called The Build, available at davesaunders.net.